it's fine. Okay, good afternoon, everyone. Yeah, so it was already mentioned before. This is not an actual presentation, but more an invitation for people who are interested in our work. And I think it's nice to mention, we were talking about this with our group recently. That was 5 years ago. We presented actually the introduction of the design of the Dutch Linguistic Intraoperative Protocol in Toulouse. And we were there with several members of our group that are also here in the audience. I would like to give you a short recap, actually, of what the protocol is. It is a standardized language battery, and we administered it in 250 healthy controls. And it is used now in the pre, intra, and post-operative phase in glioma patients. And so it consists of tests that can be used during stimulation, but also during the resection. So that means that test can be administered within the 4 seconds of the direct electrical cortical stimulation, and also tests that can take longer. We design tests for the main linguistic levels, as you can see here, at the level of phonology, at the level of semantics, syntax, also articulation, and we also take into account spontaneous speech, which is well, the usual daily conversation. So the item selection was based on formal databases, linguistic databases, and controlled for things such as frequency to control for complexity, or things such as syllable structure and manageability, for instance. So this is the list of the tasks we designed. So it looks like a very long list, and it is not actually the goal to administer everything in the pre, intra, and post-operative phase. It is actually, the goal is to select those tasks that are suitable for the patient. So it can be patient-tailored. So we look at the preoperative language level, we look at tumor location, we also look at patient characteristics, such as profession or hobbies. And it is very important to mention that you have to administer the preoperative tasks in order to be sure and to detect the disturbances and to be certain if there is an impairment during the stimulation that it is caused by the stimulation itself and not by a pre-existent language deficit. So items that were produced incorrectly, for instance, in an object naming task, we remove it in the intraoperative phase, right? So we also look at tumor location, and we looked into the literature, and we made a scheme, and this can be used as a starting point. So it's not the case that you have to administer these tasks in a certain area, but it is a guiding line. Also, we all know that brain plasticity can be here, so this is a guide. So for instance, if we look at the green spot in the superior temporal lobe, there in that case, it could be useful to administer a semantic production task. So here, this is an example of a semantic odd picture out, and here the patient has to name the item that does not fit the semantic category. So that would be the brush, and this can be administered within 4 seconds. We also have a guiding little scheme for tumors that are located at the subcortical level. So for instance, if we have tumors in the arcuate fasciculus, then in that case, phonology is relevant, and a repetition task, a word repetition task, could be useful. So we have lists of words with 3 syllables, and we designed words that were controlled for different complexity levels. So here you see the word gorilla, then you see caramel. Caramel is more complex because of the phonemic similarities in caramel. Spaghetti is more complex because of the consonant cluster sp. And the most complex item is microphone, because there's cluster, and there is a phonemic similarity. So you can actually switch in between the different complexity levels. So if a patient has a deficit at the phonological level in the preoperative phase, for instance, he has difficulties producing consonant clusters, well, you don't administer these in the intraoperative phase, and you choose the word, for instance, caramel with those syllable structure and gorilla. So that's the way how to use this protocol, right? So the goal of this talk is to invite people who are interested in adapting and implementing these tasks, or maybe subtasks of this protocol. And if I say adapt, well, I really mean adapt, and it's not a literal translation, because it's not that easy, actually. You cannot just translate an item and then administer it in a different language. It has several steps that you have to take into account. So first, you have to make a design. So you have to look at the linguistic linguistic variables, such as word frequency, and there are lists available online, and then you have to control for them. So the complexity levels have to be taken into account within the different languages. So that's the first thing you need to do. And the second step is the item selection. So if you have selected a set of items and you have controlled these items for the different linguistic variables, you have to administer it in normal population. And if well, a healthy group thinks it's quite difficult to produce certain words, well, you cannot administer in patients, so you have to remove it. So this is the item selection, and you want to aim at more than 80% accuracy. So then you end up with another list, and then step 3 is the standardization. So you collect norms in a normal population, take into account things such as gender, age, and education, and from there you can make cutoff scores and administer it at clinic, and that's the final step, clinical validation. So it's quite a long process, and we are willing to be part of that and to help also look at those linguistic variables and help to think with you to design these tasks in your language. So we already have some international partners, and there is adaptation in progress. We have a partner in Chile, and this protocol, she actually, this Carolina Mendez, she actually adapted all tasks at the moment. She's in step 3, so she's now standardizing the tasks in a normal population. So the next step would be the clinical validation. We also have partners in Italy and Sweden, and in Italy they're also administering the tasks in a normal population. It's also step 3, and in Sweden they're still designing the items. So we are in contact, and we discuss the items at the moment. And it's very interesting to learn more about other languages. So I think it's very a nice way also to look at the complexity of language. Also in UCSF, Elke de Witte has worked there last year, and during that period she also adapted with some colleagues some subtests of the protocol. So it's step 2. So this is the invitation, this is the protocol. If you are interested, well, you can email me and we can discuss it. Well, I can imagine that there are some questions maybe. So feel free to ask the questions right now or maybe later if you want to think about it. And these are our acknowledgments and the centers that we have collaborated with. The Erasmus Medical Center, the neurosurgeons, the ZNA Hospital in Antwerp, AZ St. Lucas Ghent in Belgium, and University of Groningen. Thank you.
Okay, thank you very much. Any questions for Dr. Satoer? Any commentaries? No? Okay, thank you very much. So now comes the time of the final decision, not